Yeah, I'm Tim Wright. I'm from North Carolina. I've been involved with this for quite some time now, and I'm going to present a little bit about some of the, and you've heard about some of the issues, but talk a little bit about some of the issues related to the oral manifestations and the management of EB. And just as a backdrop, and you guys know this better than I do, this is a very diverse group of conditions caused by, and you heard this morning people talking about the genetics of this. You know, I'll have people call up and say, well, I got a kid come in the office with EB, and how do I treat him? I'm like, well, it's like saying they got two legs. I mean, there's just a whole lot of different things out there. So really the oral manifestations are very much typically predicated on what kind of EB they have and the severity of that. So simplexes are different than junctionals. The dental manifestations are different in junctionals than they are in the dystrophics, and kindlers are not as well studied from oral manifestations. A lot of what I'm going to present, a little bit about the oral manifestations, is data that was derived from my involvement with the EB registry, the National EB Registry, which there was a site in Birmingham, Alabama, and I was there with Joe David Fine at the time, and then he went to North Carolina, and I subsequently went there. So some of what we know about the oral manifestations, a lot of what we know actually was derived from the National Registry, which did a lot to really elevate our understanding of these conditions. So the soft tissue manifestations are highly variable, again, depending on the specific type. But some of the things, the hallmark, of course, is increased fragility of the mucosa. So just like the skin and the oral mucosa and the GI tract that we've been hearing about, increased fragility is sort of the hallmark. And it varies, the amount of that fragility is very different between different patients and different EB types. You can have significant perioral lesions, microstomia, or this decreased oral opening, ulcerations of any of the soft tissues. The ankylosing you heard during the anesthesia talk is the binding down of the tongue. And then obliteration of the oral vestibule, which is where that is where your cheek comes down and attaches down below your teeth. That's the vestibule. Your mouth and the soft tissue is designed to take food in and channel it out and swallow it down. And EB does a whole lot from a soft tissue point of view to mess with that, with the scarring, and especially in the dystrophics. Not exclusively, but especially in the dystrophics. So as far as the soft tissue manifestations, again, all EB subtypes that we looked at in the registry can have increased fragility, but it was really the recessive dystrophics were the most significantly involved, followed by the junctionals and the dominant dystrophics. But even in simplex, you will have people who will report things that, they'll have an increased frequency of having oral ulcerations, and they can be precipitated by dental procedures. So some people will say, yeah, if I go to the dentist, I'll end up with ulcers after they clean my teeth and they go manipulate. So, if you have any EB type and you're going for oral health care, you need to let them know what is your history of your oral involvement. Do you get lesions? Do you not? So high percentage of all of them will, but simplex not typically is involved. And junctional, typically not nearly as fragile as dystrophics. But there's some very fragile junctionals as well. We actually measured in all these individuals that came in for the registry, I would measure their commissure to find out the actual width of the mouth and how it varied between the different EB types. And normal mouths are about 45 millimeters. And you can see that simplexes were about the same as normal, even in the more severe generalized, maybe a little bit less. But it was really when you got into the Hurlitz junctionals, because they have perioral lesions, so they tend to have a diminution in the commissure to commissure, corner of the mouth width. And it was the generalized recessive dystrophics that had the most significant diminution. It was interesting when you measured an infant. If you measure a little kid, a 1-year-old, their commissure to commissure is about 25 millimeters, and they just don't seem to grow and continue. We think about it maybe as being a scarring down process, and there's probably some of that, but they just don't ever get as wide as they normally would. They start small and they sort of stay small. It's important for oral soft tissue screening, especially in the recessive dystrophics, but can occur in other EB types. There's a risk for oral carcinoma. Actually was looking online, checking out the literature, and there was a report in in a simplex patient with a novel Karen14 mutation. Anybody can get oral cancer, but EB individuals with different types of epidermolysis bullosa, especially recessive dystrophics, most of the cases have been reported with that, are at increased risk. So you want to make sure, and self-examination is always good, because most recessive dystrophics will have lesions in their mouth, essentially all the time. If you notice one changing, so that it has rolled borders or it becomes larger, or if you notice that something changing in there, that's something you should really have checked out. And ideally have a professional, somebody who's used to looking at soft tissues, evaluate that. Soft tissues in a recessive dystrophic mouth, it looks different than the normal, so somebody that has a history and can longitudinally follow you is better than just going in cold turkey. This is an example. This is a child with a Hurlitz. Sounds like work. I was kidding. So, and you can see that this individual's does not have ankyloglossy, and the tongue sticks out, and they have papillae on the tongue, but has lesions on here. And it's like a chronic burn patient. If you have chronic lesions that heal and wound and heal, then you're more likely to develop carcinomas. This was like a 9 or a 10-year-old that had this significant rolled border lesion that was white, and we biopsied it, and it was pre-malignant in a 9-year-old. I think the youngest that's reported is maybe a 15-year-old, but to have an oral carcinoma, but can occur fairly young. So something, again, you want to be aware of. And this is recessive dystrophic, where the papillae have all been eroded away and ulcered off. So how do you manage the oral lesions? It's palliative. There's really, and most people I know don't really do much. They just live with them. It's what they're used to, what they know. There are things on the market, not really tried and tested in EB, but if you had a localized lesion in a simplex or something, there's Orabase, which is a cyanoacrylate, and you can paint it on there. There's another product called Xylactin. Xylactin has got an alcohol solvent in it, and so when you put it on, it burns like crazy. So most kids don't want to use that, or most adults don't. Other things that have been, the only thing that's actually in the literature for stomatitis in the mouth for management, which again is palliative, is sucralfate, and this was published in 2001 in the Journal of Periodontology. This is a medication that's used predominantly for ulcers. You swallow it. It's for gastric ulceration. They reported this, and in a series of 5 recessive dystrophics, 5 people, they said they got improvement. So that's the total data on that. Some people have used the magic mouthwash. Again, it does have xylocaine in there. It's got Benadryl, and Maalox helps coat things. That's not something you'd want to use in a little kid. There are issues about using topical, like even for teething, things that have lidocaine or benzocaine for topical treatment in infants, because they can develop systemic problems from that. So that's out there again. I don't know many people that actually, they don't like the taste, they don't like to deal with it. They just deal with the ulcers and don't, drink orange juice or do whatever it's going to irritate the ulcer at the time that it's bothering. But these things are out there. Candidiasis can be an issue. I mean, it can be an issue in kids in general, but if you have a lot of lesions in your mouth and you have trouble cleaning your mouth, then we found actually when we evaluated the folks in the EB registry, there was a higher prevalence of candidal overgrowth in that population, probably just because they've got mucosal issues anyway. And so normally the treatment for that is oral nystatin is the simplest thing, but there's also other drugs that you could use, ketoconazole or atrocious and things you could have. Chlorhexidine rinses can reduce candidal overgrowth if there's issues and problems with that, which is usually a white plaque that grows in the mouth. And it's very uncomfortable. If you have taken oral antibiotics like amoxicillin or something for ear infection, it's not uncommon then to get your bacteria out of kilter and you'll have an overgrowth of that. So something to watch out for. Dental problems that will again vary between the different types. The main things that you'll see are enamel defects, enamel hypoplasia, which is a deficiency in the amount of enamel. They can be generalized thin enamel or pitted enamel like this. That's typical of junctionally B. In fact, 100% of all the people we've ever looked at with junctionally B had enamel hypoplasia of one type or another. Dental caries is a big problem, can be, and dental crowding, which is especially an issue in the recessive dystrophic. Caucasians tend to have crowded dentitions anyway, but then if you're diminished in size but your teeth are not, so you're trying to pack a whole bunch of big teeth into a little head, you tend to be crowded. When we looked at the enamel defects, again, we saw that in the junctionals, there were 100% of the individuals had enamel defects, whether they were Hurlitz or non-Hurlitz, and at that time we didn't have all the mutational analyses that you have today, but of all the mutations that are known to be associated with junctionals, they all have enamel defects. Simplex, not that much different than the control group, and even the dystrophics. The recessives seem to be a little bit higher localized, and that may just be due to stress. If you have a lot of neonatal stress or stress during systemic stress, tooth development is relatively sensitive to those kind of stresses, hypoxia, fever, those kinds of things. So that may be partially why you're seeing an increase here a bit, but this is the group that really has it. Occasionally there have been reports in the literature of a dominant dystrophic that has enamel defects, generalized. And in the enamel defects are most pronounced in the junctionals. Like I said, 100% of all the studies, all the cases that have ever been reported in the literature and all the ones from the registry had enamel defects. So they could make the teeth look very small because they're lacking the enamel. Otherwise, the teeth were shaped relatively normal. It's essentially an enamel defect. They could be very pitted like this. This is an electron micrograph just showing you'd have all these little tiny pits in there. One of the problems with that is that predisposes the teeth to tooth decay. Your prime defense mechanism for the tooth is that outer enamel. And the better it's mineralized and the smoother and more intact it is, the less likely you are to have colonization of microorganisms and then subsequently decay. So caries risk. Enamel defects is a big one. You also frequently will have consumption of high caloric diet. If you got kids who are on Pediasure to try and jack their caloric intake up, the second ingredient on Pediasure is sugar. So fermentable carbohydrates doesn't have to be high calorie, but frequently if you're trying to jack calories up, that's carbohydrates. And they're frequently fermentable by the bacteria. They eat what you eat, and then they make acid. They leave it on your teeth and they dissolve. The slow eaters, there's nibblers and gobblers. I sort of eat like a snake. I throw the stuff in the back of my throat and boom, kind of done. But if you're sitting around grazing all day long and it takes you a long time to eat, that's a problem. From a caries point of view, that puts you at risk. But if you've got issues with swallowing, you've got issues with your mouth and all of those kind of things, you're probably not going to eat quickly. Reduced oral clearance. I mentioned about the structure of the soft tissue. Your tongue and the oral vestibule are a critical part of the design to get that food into your mouth and then swept back. If you get, when I get a piece of food stuck up in the vestibule, I can take my tongue usually and lick it out. Or you'll see me at the back, back there picking it out. But, ideally your tongue would do that. Again, in a recessive dystrophic patient, that's probably not going to happen because they almost uniformly will have ankylosing, some variability, but pretty much they're not going to be able to do that. And frequently, many of the things that they would use for their own oral hygiene are going to be very difficult because to get a toothbrush back to where those teeth are when your cheek is tucked down tight, bound down essentially right next to the collar of those teeth, to get right around the necks of those teeth is going to be very difficult, potentially painful, and potentially cause a bunch of ulceration. So that's a problem. And a lot of the things that we would use, mouth rinses, toothpaste, are highly flavored because most people like to have highly flavored stuff. Well, a lot of that, mint is frequently not what a child with oral ulcerations wants to have in their mouth, or a mouthwash that has a lot of alcohol in it. Listerine is 28% alcohol. So there are products out there, though, that have a reduction of those kind of things to lessen that. Getting professional care can be a problem for a lot of different reasons. As somebody mentioned earlier, when confronted, a dental practitioner with a patient with epidermolysis bullosa can be daunting, to say the least. So they're not necessarily comfortable with it. So finding them and finding somebody who's going to help can be a problem, and then being able to receive it can be a problem. So the prevalence of caries, what we found out was that if you looked at the control group compared with the simplex and dominant dystrophics, they're all about the same tooth decay rate when we did that. The two big groups that had a lot were the junctionals and the recessive dystrophics. Here, predominantly because of, not exclusively, but predominantly because of the enamel defects and some soft tissue component coupled with that and dietary issues, here it was more related to the soft tissue issues. I've said if you wanted to create a tooth decay machine, EB is it, because you've got soft tissue, you've got diet issues, you've got enamel issues. I mean, you've got a whole lot of things that are going to put you at very high risk for having tooth decay. So how do we prevent that? You just heard about diet control, and again, that can be very challenging because if you're a slow eater, I'm not going to take somebody who has trouble swallowing and make them a fast eater. It's just not going to happen. If you've got to have high caloric intake to maintain body weight, then you've got to do that. So there are some things that you could do around that, and one thing that you could do is talk to a dietitian and find out how do you maximize those things that you're going to have to do, but maybe incorporate the most tooth-friendly things you could do, and also maybe have some other routines, like when you get done, snacking at this point in time, maybe you could drink some fluoridated water to try and wash some of that out of your mouth. And again, even to sit and swish and spit vigorously or swish and swallow is very difficult if you've got a lot of soft tissue involvement. But having that fluoride exposure could help. So coming up with a plan that would fit with your routine and fit with what you have to deal with from a medical weight and all those other issues is something that should be done. Mechanical plaque control, brushing and flossing. Flossing would be extremely difficult to get back from an oral access. If you've only got a 30 millimeter space that's that big, I couldn't even get my two big old fingers back in there, So that would be difficult. But ideally, if you could do those things, and there are flossing aids on little fork things that you could use to help do that. Again, you've got to be very careful because if you're snapping floss down in there and you're irritating the tissue, the kid's not going to like it, and that's not going to be a behavior that they're going to want to have reinforced. So that's something you could work on. Just rinsing out with water, again, is a form of trying to help clear some of that food out of the mouth. Chemotherapeutic control, fluorides, you want to make sure, ideally, that you have optimal exposure, drinking water. If you're on a well or a non-fluoridated municipality, and I think about 74% of the people in the United States now have access to fluoridated water. But if you drink bottled water all the time, most of that doesn't have fluoride in it or doesn't say. You don't know. But there are ones out there you could buy that have fluoride in them. And toothpaste and rinses. Fluoride is probably the single most effective thing for caries control that we've got, especially for this population. Protective coverings, sealants, crowns. If you have enamel defects and if you've got junctional EB with enamel defects, then you can restore the teeth and cover them up. Which doesn't mean they can't decay, but it makes it a whole lot more difficult to decay. Toothbrush selection, if you have microstomia or you've got severe fragility, you really want something with a small head, and there are those on the market. Most of these are like adult periodontal type brushes. And some of them are very soft, so the bristles are very soft, and these are actually kind of cool because they're even angled back, and they're just little brushes like that. Soft bristles are good. You can get the bristles even softer by running them under warm or hot water right before you use it. That'll just soften up the plastic a little bit. You can actually even take a regular toothbrush and cut the head down if you want. Get a Dremel tool or take it to the dentist. We love doing stuff like that, making whittling, carving and stuff. Give me that toothbrush. I'll make whatever, turn it into Mickey Mouse for you. Here you go. There are, people ask about mechanical brushes, water picks. Water pick's not a bad thing. You probably have to turn it down pretty low if you've got really soft, a lot of soft tissue fragility. But you could turn it down low and put a little fluoride mouthwash in there and have a very low jet and help irrigate the mouth out and wash away debris. That's another option. Mechanical toothbrushes are as good as where you get them. I don't mean where you buy them, I mean where you put the head brush. So if you don't get it where it needs to go, it's not going to do any good. And most kids, if you give them a toothbrush, what do they brush? They brush the tops of their teeth on the right side, maybe. Okay, I'm done. I don't think so, Junior. So, this was actually I guess it's DebRA of Australia sort of recommend this Rotodent. This thing spins around like a dental. It spins fairly slow. But this is real soft nylon, and it's got a very small head on it. It's kind of like the size and shape of a dental tooth cleaning thing. And you could try that. I tried it on myself. I personally didn't like it, but there are other people I know that do like it. And you can have your dentist can help you get it. I don't think you can buy these at a store. Actually, if you want, you could probably order them directly from this company, and they sent me all this stuff, and they know about DebRA. So that would be something you could try. One of the things that we have in our armamentarium that's been around since, I guess, the mid-90s now, in this country, it's been around in Europe for years and years, is Fluoride Varnish. And you can paint this on the teeth. It's professionally applied topical agent as opposed to the old acidulated phosphate gels where you'd sit with like a tray in your mouth for 4 minutes. Well, that doesn't work really very well if you have a lot of issues. One, just even the size of your mouth to be able to pop trays in there. I do like to do those to kids though and take their picture and put them on the internet or stuff like that. But and this is actually an EB kid, a recessive dystrophic being painted, and you can see that's as much vestibule as this child's got in the anterior. So they're being treated in the operating room. They're intubated. There are also higher concentration fluoride toothpaste. Regular toothpaste over the counter in the States has got about 1,100 parts per million, 1,000. There are prescription ones. You can't buy them over the counter that are 5 times that strong. And after a child's 3 or 4, you could probably start using those if you wanted to. Again, you'd have to get a prescription from a dentist to do that. But if you're having problems with caries, this is something, if you're having problems with caries, you got to be relatively aggressive trying to control it, because treating it is a lot more difficult than preventing it. So, time is up. I'm almost done. Chlorhexidine rinses. We used to think this would help as a chemotherapeutic for caries. It doesn't. It helps for candida. So, and there are still groups out there recommending this for caries control in dentistry, but the data doesn't support it. Dental restorations. If you've got a lot of soft tissues and caries problems, you can use stainless steel crowns. There's no contraindication to any of the materials we use in dentistry for an EB patient. This is an example of a junctional before and after being restored. Again, trying to make them as aesthetic as we can. If I did this today, these would probably be white. This is a young boy with junctional, and he had missing teeth, and these all missing enamel, and put this in, and got him a smile. He said, "I never had a smile before." So this is an adult with full mouth, crown, and bridge. So for $48 million, you can have that smile. It's not cheap. That's not cheap. I may be easy, but I didn't do that, actually. It's not my work. This was people ask about implants. You can have implants. There's issues about putting them in, access, the bone available to put them in, having the oral opening big enough, and ability to maintain them. But she had this neat little denture. She got a pretty small mouth, and a couple of dentists at Detroit Hospital in Michigan did this for her, did a really nice job. So it can be done. Mildly affected, usually you can do dental treatment with minor modifications. Severely affected, general anesthetic. So if they got a lot of soft tissue problems, rampant caries, or you've got to do a lot of invasive stuff, we're frequently taking them to the OR to do these kind of treatments. And you heard about this. Usually it's endotracheal intubation. You do everything as atraumatic, lots of lubrication, no adhesives. And you can do these things quite safely with all the monitors without using any adhesives. So pulse ox, IV securing. And again, if you've got a team, as you heard about from the anesthesiologist, this again is a team deal, you can do it quite safely. Not that it doesn't have risk, but you can do it pretty safely. There are probably, I would venture to say, there's got to be thousands at this point of general anesthetics with EB that have been done and reported safely. So some of the things that 30 years ago we were concerned about, we don't know are not concerns today. There's still a lot to be concerned about. So dental management, early intervention, a dental consult is key. You want regular oral evaluations, especially you want to be concerned not to have oral premalignant lesions, aggressive prevention, and restore before you have advanced destruction. And a lot of what the patients with EB deal with are the same thing as everybody else. You know, I'm a pediatric dentist, so this little guy, one of my patients, came in, and the first thing out of his mouth as he came in was, "I hate the dentist." Hey, join the club, man. So I don't particularly like dentists either. So, anyway, given the restorative therapies and prevention, we can really do a great job keeping these kids having good smiles and feeling good about themselves and having as optimal nutrition as possible. So this was a guy that I did a year or two ago, and he was right before Thanksgiving, like 2 days before, and all he wanted to do was get home and have his Thanksgiving dinner, and he sent me this picture on Thanksgiving so anyway, thank you very much.